Good morning. It is a great pleasure and an honor to be here again in Tirana. If there are any stomatologists in the room, you must go now. The meeting is over there. Professor Petrela suggested I talk to you about my experience of stereotactic radiotherapy, since you'll all soon have access to the splendid new X-knife which is being installed in the Nuna Teresa Hospital. And I've called my talk The Uses and Abuses of Stereotactic Radiosurgery for reasons I will discuss. So, with modern technology, with better brain scanning, with safer surgery, and accurate high-dose radiotherapy, this gives us more and better ways of treating patients. But it is very expensive, and decision-making has becoming more difficult because there is more choice. And as a result of that, the need for evidence to guide decision-making is becoming more and more important in modern high-technology neurosurgery and neurology. Economists talk of the law of diminishing returns. In the y-axis, you have output, and on the x-axis, you have the resources you are investing. And most modern medicine, we are now operating out here. In other words, we are having to spend more and more money for very small benefits to our patients. Modern chemotherapy drugs cost millions of dollars, but many patients will only live for a few months longer. So the question of evidence to decide how to treat patients is increasingly important because it is so expensive, and all modern healthcare systems are in a state of financial crisis because we cannot afford the increasing cost of modern medical treatment. I will talk about stereotactic radiosurgery under 4 headings. I will talk about the technology, I will talk about the indications, the evidence to guide us, and some of the controversies and arguments. The literature with radiotherapy is very confusing. There are many different names. I'm not sure if I completely understand it all myself properly, but we talk about conventional external beam radiotherapy. This is the traditional radiation treatment. It is given in many fractions every day over several weeks, and the radiation dosage is usually between 1.8 and 2 gray for each fraction. It can be delivered by linear accelerators, as you will have with your new facility here, and it is accurate to within 2.5 to 5 millimeters. Stereotactic radiosurgery, if you use the word radiosurgery as opposed to stereotactic radiotherapy, is a highly focused, single fraction, high-dose radiation treatment where the radiation dosage will be between 15 and 25 gray, and it aims to destroy its target, whereas conventional fractionated external beam radiotherapy depends on differential sensitivity of the abnormal from normal surrounding tissue. And the various names you will certainly have heard of. There is gamma knife, there is cyber knife, which is essentially a LINAC linear accelerator system on a stick, LINAC on a stick, or there's a LINAC system such as the one you have here. Novalis is the system made by Brainlab, X-knife is the system made by Siemens. Gamma knife treatment was invented by the genius, brilliant Swedish neurosurgeon Lars Leksell. It is very accurate with it less than 1 millimeter. The system is bolted, is fixed rigidly to the patient's head, so the patient's head cannot move. You do not need any real-time imaging to control the system, and you can only treat a patient's head. There are academic, commercial arguments as to whether CyberKnife or Gamma Knife is more accurate, but from a practical point of view, my radiotherapy colleagues tell me it is not an important difference. That is an advertising picture of a Gamma Knife system. It uses radioactive cobalt, and as you can see, the radiation is all focused in narrow beams to concentrate on one small target. So the target gets a high dose of radiation, the surrounding brain gets a low dose, but it does get some radiation. The CyberKnife treatment is a robotic mounting of a Linux system which allows for the movement of respiration, so you can treat moving targets, and as a result it means you can use it for treating the rest of the body. You can treat spinal lesions, you can treat prostate cancer with it, things like that. Now, the uses of stereotactic radiosurgery in current practice, you can use it for cerebral metastases, for acoustic neuromas, for meningiomas, for pituitary adenomas, for arteriovenous malformations, possibly cavernomas. The evidence is not clear. You can use it for trigeminal neuralgia. It can be used for functional surgery, for pain, for Parkinson's disease, and if you have a CyberKnife, you can use it for extracranial treatment, which I will not discuss today. There we are. So in the treatment, I'll talk first of all about metastases. As you know, class 1 evidence means evidence from randomized controlled trials and is the strongest, most scientific evidence for guiding decision-making. And there is class 1 evidence that a single dose of stereotactic radiosurgery with whole brain radiotherapy is better than whole brain radiotherapy alone for a single metastasis and up to 4 metastases if the patients are reasonably well with a Karnofsky performance score of better than 70. That is evidence from a randomized controlled trial. There is class 2 evidence, which is a non-randomized trial, showing that a single dose of stereotactic surgery with whole brain radiotherapy is better than whole brain radiotherapy alone in patients with a Karnofsky score of less than 70. And there is class 3 evidence, which is purely an observational study, that single-dose stereotactic radiotherapy with whole brain radiotherapy is better than whole brain radiotherapy for metastases if the Karnofsky score is less than 70. If you are a little confused already, that is the appropriate response. This is a very confusing area. The evidence, there are many publications. The radiotherapy literature is very difficult to understand. At least I find it difficult to draw definite conclusions. There is class 2 evidence that surgery with whole brain radiotherapy is as effective as stereotactic radiosurgery with whole brain radiotherapy. And there is class 3 evidence that possibly stereotactic radiosurgery by itself or surgery by itself may be as good as surgery with whole brain radiotherapy. In other words, if you treat a single metastasis with either surgery and the surgeon thinks he's removed the tumor completely, or if you treat the single metastasis with single fraction radiosurgery, there is some evidence that you do not need to give further radiation treatment. And certainly in my own clinic, if we think we have treated a single metastasis completely with either surgery or radiotherapy, and I'll talk later about how we decide, it is reasonable not to give whole brain radiotherapy. You can wait, you can repeat the brain scan 2 or 3 months later to see if there is any recurrence. But that is class 3 evidence. It has not been shown yet in a randomized trial. What are the risks of treatment for metastases? Well, the main risk is a radiation necrosis, which is a serious risk, And that risk increases as the size of the target increases. And most radiotherapists reckon that beyond a volume of 20 cubic centimeters, if the tumor is bigger than 22 centimeters, which for a spherical tumor, a ball-shaped tumor, it means about a diameter of 3 centimeters, the risk becomes too high. So stereotactic radiosurgery is not used for tumors or AVMs, arteriovenous malformations, which have a diameter greater than 3 centimeters. There are exceptions to that. There are some papers published saying you can treat, but the risks are certainly much, much greater of causing radiation necrosis to the brain next, immediately close to the target, because it is a very high dose of radiation and it destroys the tissue it hits. Is there an upper limit to a number that can be treated? Well, I saw a presentation from Greece recently, and I've read one paper from America where people are treating up to 10 metastases. There is no evidence this is very effective. It is certainly very expensive. And we must all remember, when treating patients with metastatic disease to the brain, that 40% of the patients with untreated metastases will die from the cerebral metastases, but 60% will die from the underlying malignancy. Most of the patients are going to die because of the rest of the cancer. So you must always treat cerebral metastases with reference to what is happening to the rest of the disease. In the United Kingdom, I think it is probably what we can generalize, the decision-making between neurosurgery and stereotactic radiosurgery is we will operate for tumors, for metastases on the surface of the brain, if there is only one, and if we can get at it fairly easily surgically, or if the tumor is greater than 3 centimeters with life-threatening mass effect, and provided that the prognosis for the patient is better than more or less 6 months. But all these patients will die sooner or later. And we use stereotactic radiosurgery for tumors deep in the brain or for multiple metastases, but subject to the total volume of the tumors, and again a prognosis of better than 6 months. Acoustic neuromas is a long subject. I gave a lecture to Professor Petrela and his colleagues yesterday about acoustic neuromas, so I'll keep this short and simple. Firstly, one can use radiotherapy for acoustic neuromas under 3 centimeters in diameter. One can use it in tumors that are growing bigger. If you see a patient with an acoustic neuroma, there is no urgency. You do not have to make a quick decision what to do. And in my practice, usually I do not do anything to begin with. We get another scan in 6 months' time. And if the tumor is growing, then we will decide what to do. So we will consider radiation in tumors under 3 centimeters, in tumors that have been shown by a follow-up controlled scan to be getting bigger, in tumors where there is no brainstem compression. If there is brainstem compression and you use stereotactic radiotherapy, the risks, it is quite dangerous. But there is a lot of controversy and uncertainty as to how to treat tumors which are smaller than 3 centimeters. Is surgery better? Is radiosurgery better? Do we use both? Do we use conservative treatment? I will not discuss this now, but there are many, many questions. There is also the question of whether to use radiation in younger patients. Some radiotherapists are worried that in a young patient who will live another 40 or 50 years, they may live long enough to get what are called the late after effects of radiation, which is a new cancer or vascular damage. Other people, Dale Lunsford in Pittsburgh in America, which has one of the largest series of patients think that risk is about 1 in 1,000. So it is a small risk. And there's also a lot of argument about the question of hearing preservation. It is certainly the case that in the short term, by which I mean 2 or 3 years, radiotherapy is better than surgery. It is very difficult to get hearing preservation with surgery if the tumour is bigger than 1 centimetre. But nobody knows what happens after 5 or 10 years. I suspect all patients, or most patients with acoustic neuromas, end up completely deaf, whether they have surgery, radiotherapy, no treatment, or both forms of treatment. But in the short term, in 2 or 3 years, there is reasonably good evidence that hearing is preserved in the bad ear for a while. So to summarize quickly on acoustic neuromas, small tumours under 1 centimetre in older patients, over 50 or 60, usually do not need treating. If there is complete hearing loss, treatment is only necessary if the tumour is shown to be growing or if it is very large and there is hydrocephalus and mass effect, and then the treatment has to be surgery. So in older patients with small tumours, most of them do not need radiotherapy, and many of these tumours never grow, or they grow very, very slowly. I'll come back to this question, because then we are talking about the abuses, the misuse of stereotactic radiotherapy. With meningiomas, certainly in America and most of Western Europe, surgery is considered the treatment of choice. The radiotherapy literature is very large and very confusing. It is largely retrospective. There are no controlled trials. The technology is constantly changing, so it is very difficult to compare one publication with another publication because they've given the radiation in different fractions and different dosage with different technological delivery. So it is difficult to draw definite conclusions. There has been little attention paid to morbidity. Most of the radiation literature is reported in terms of mortality, how long patients live, not in terms of quality of life, which as neurologists and neurosurgeons we all know is very important. But in general terms, the literature claims an 80% control rate in 10 years, but no control trials. Fractionated stereotactic conformal radiotherapy, which is what you will be able to give with your new machine, is theoretically safer than conventional external beam treatment, but again, the published literature does not report complications in a clear way. Similar control rates are claimed for fractionated stereotactic treatment to external beam treatment. Reports claim a huge variety, 14% to 44% of actual neurological improvement and 5% neurological damage. There is a new form of radiation called intensity modulation radiotherapy, which theoretically might be better. And again, proton beam treatment, which is available in Heidelberg, Paris, in Boston, and Florida, is theoretically less damaging, but the evidence is not there. It is a theoretical thing to do with proton beam scattering. So with stereotactic radiosurgery for meningioma, there have been 18 studies published of almost 3,000 tumours, 5-year control rate of 91%, and 7 studies report 87% at 10 years. There is no difference between gamma knife and LINAC, 5% permanent complications, and stereotactic radiosurgery should not be used in tumours near the optic nerves because it is very damaging. Near the limit is 3 millimeters. With arteriovenous malformations, again, treatment for a nidus under 3 centimeters, 80% of AVMs will have occluded, will have completely thrombosed. With small AVMs, it is very important when treating AVMs, you must get rid of it, you must occlude it 100%. If there is a little bit of AVM left behind, the risk of hemorrhage remains the same. The failure rate and the complication rate is higher with bigger AVMs. So the treatment is fractionated radiosurgery, 4 AVMs, or single-dose treatment with gamma knife. Until recently, gamma knife could not be fractionated. Now it can be. So again, it is all increasingly complicated and at times confusing. Whether pre-treatment embolization helps or not is uncertain from the literature. The complications of treating AVMs is it takes 2 years to work, and there is still a risk of bleeding during that time. The theoretical advantage of surgery is you remove the AVM immediately, so there is an immediate reduction in the risk of bleeding. And radiation necrosis, which does happen, and I've seen some very bad cases of radiation necrosis from AVM treatment. The literature reports 3 to 7% incidence, and that has to be balanced in the decision-making against the approximately 2 to 4% risk per year, per annum, of serious hemorrhage. With pituitary adenomas, stereotactic radiosurgery, rather than external beam treatment, can be used provided the tumour is more than 3 millimeters away from the optic nerves. And theoretically, it is probably best for the endocrine active tumours, for acromegaly, for Cushing's disease, which are usually microadenomas, and where the purpose of the treatment is to destroy the tumour completely, which is what stereotactic radiosurgery will do. For trigeminal neuralgia, it can be used if medical treatment, if drug treatment with tegretol, carbamazepine, lamotrigine, gabapentin, whatever, if drugs do not work. There have been no well-conducted studies or trials comparing stereotactic radiosurgery with surgery. There is a big variation in the reported success rate. Some papers report a 30% immediate response. Some report 90%. At 1.5 years, between 0 and 14% of the pain has recurred, and there is about an 8% incidence of sensory loss in the face. So the conclusion with stereotactic radiosurgery for trigeminal neuralgia is that it is safer than microvascular decompression, but less effective. And in England, we do not usually use it unless there are medical contraindications to microvascular decompression surgery. What about the abuses of stereotactic radiotherapy, which is my last slide? Firstly, patients, of course. We are all frightened as patients of the surgical knife. We want the idea of treatment without a knife is attractive, and patients are easily exploited. Because in commercial healthcare systems, as in America, as in Belgium, and in Turkey, it is very profitable. Stereotactic radiotherapy, there is a lot of money. Every time you see a metastasis on the brain scan, you're looking at $10,000. And with trigeminal neuralgia, patients will be excited. You can say, we can treat you without surgery, which is why it is so important that we use evidence to guide our decision-making. There have been no controlled trials. Most small acoustic neuromas do not grow. But if you look